All right. Hello, everyone. Happy Tuesday. I hope everyone's having a wonderful day, morning, evening so far. Welcome to another virtual morning report. Right off at the beginning, I'll just ask anyone if anyone has a case they would like to present. Today, I have the privilege of getting to discuss with Ravi. So I'm really, really excited to, all learn together, discuss a case. So if anyone has a case, please make yourself known, put your name in the chat. We'd love to have a case to discuss. Ravi, how are you doing?
Oh, I'm doing wonderful. Just had a busy morning, but it's absolutely a blast to be here today to discuss a case and have CPS family here, Hans, Leah, Madalena, Deborah. Always good to be with you here. So appreciate this opportunity today to learn from all of you, to learn from all the crowd here. Type in the chat, please. If you have any ideas, we'll definitely glean some ideas from that. And again, if you have a case, please do present a case. Step up and present the case. Back to you, Madalena.
All right. Well, it's great to see everyone. I always like to see, are there any new people who are joining VMR for like the first or second time? It's always great to kind of meet new people who are tuning in. Maybe everyone's been here for a little while. Okay, we'll give a last minute call out for any cases. Otherwise, we do have a backup case, but just wanted to send a last minute call out for cases. All right, it is quiet. Well, Deborah, do you mind presenting your backup case?
Let's do it.
Awesome.
Hi, everyone. Nice to be with you all here today. So let's go for our case. So it is a 37-year-old female that presents with hypertension and shortness of breath. The patient say that she spent 6 months in US and 6 months in India each year. And she see a primary care every 6 months and has no history of high blood pressure or renal disease. 5 days before, she was excellent health, and then when she started to develop some dyspnea, and then 2 days before she had orthopnea, and 1 day before she had been taking 200 milligrams of ibuprofen, but didn't improve her symptoms. And then in the emergency department, one thing noticed was her creatinine that was 5.2 milligrams from deciliters. I'll stop here.
Madalena, what do you think?
All right, so this is quite a lot of interesting information already in just the first aliquot. So thank you, Deborah, for presenting this case. So just to summarize what we know so far. So this is a relatively young woman, 37 years old, who sounds like she spent 6 months in the US, 6 months in India. Just want to summarize here. Regular primary care visits every 6 months. Sounds like she's connected with care. And she has this, seems like new symptoms of hypertension and shortness of breath. And so the first thing I want to do is try to clarify the time course. So this was 5 days ago, she developed the shortness of breath. Is that right, Deborah? Okay. So I'm going to be bucketing this into a subacute time course. And when we think of shortness of breath, we've talked on many VMRs that 95% of the causes are generally cardiac and or pulmonary in origin. So those are really kind of the organ systems that we want to be prioritizing here. I think, because you really want to see, is this potentially a morbid disease that we want to be ruling out initially, particularly, a cardiac disease. And the fact that there are 2 days of orthopnea kind of stands out to me as a concerning feature here. So I would also want to look for other signs of, cardiac dysfunction. So is there elevated jugular venous pressure? Is there bilateral pulmonary edema or bilateral lower extremity edema? The other thing that stands out to me is the creatinine of 5.2, which is very elevated. So I think the first additional piece of information I'd want to get is what is the baseline? But to me, there seems like there are multiple, there's kidney injury, there's potentially either pulmonary or lung involvement. So I think those are all the things I'm tracking right now. There's a lot of reasons why you can get kind of a pre-renal injury with, low cardiac output, for example, which is something that may be a way to link these two things together. But I think right now there's a lot of different symptoms I'm tracking: shortness of breath, hypertension, kidney injury. So I think for further information, I want to tease out, this hypertension and how was that diagnosed? Did she go to a primary care visit and was informed she had hypertension, or did she take her blood pressure at home? That's some more information I would want to clarify. Ravi, with all of this information, what are you thinking?
Absolutely remarkable, Madalena. I'm very impressed you've highlighted a lot of the relevant information here, but what I'm very interested in is the hypertension the cause of the shortness of breath, or the shortness of breath, which we're predominantly thinking is a volume issue, causing the hypertension? So there is some interplay between both of these presentations, and in a young patient and highlighting renal injury. So we don't know if this is an acute or part of a chronic complex. Is the focus on the kidney itself? Are we dealing with a nephritic condition? So as we accumulate more data, we will determine if our focus should be, or the center of gravity is, pathology of the kidney here. But like you astutely had mentioned, the heart is commonly causing a lot of the presentation of shortness of breath here. So when I think of shortness of breath, I think immediately of, you can have the dyspnea pyramid, you could have an anatomical approach going through the upper respiratory tree, the bronchial tree, and then the 3 A's: anxiety, acidosis, and anemia. And we've had a plethora of anemia cases manifesting with shortness of breath as the initial index complaint. But right now, I am deeply thinking, like everybody else here in the chat is thinking, this kidney is something sinister is happening. And are we dealing with, right off the bat, I'm thinking nephritic syndrome, where you have edema, acute kidney injury, you have hypertension as well. Could that be the explanation for this initial HPI here? I'm not sure, but I think we're getting pretty warm. This 200 milligrams of ibuprofen, again, we don't want to discount medications. What could it do? I think Mona had mentioned that ibuprofen can exacerbate volume issues, can also exacerbate renal issues. So this, I would definitely, like you'd mentioned, track it, keep it on the back burner to bring out later if it does explain some of the conditions that's going on here. Back to you, Madeline. Anything else you would like to add before we go on to the next aliquot?
Yeah, I think the one thing that you said that stood out to me, which I think is such a fantastic point, is looking at the hypertension and asking the question: is the hypertension a cause of some of these symptoms like shortness of breath, or is it a consequence of the syndrome that's underlying? And I think a helpful framework that's for hypertension that's come up in past VMRs is kind of the 3 buckets you can put hypertension in. Like, is this acute hypertension or chronic hypertension? Chronic hypertension, you can split that into primary and idiopathic, or secondary due to a specific cause. And it's interesting that Deborah said that she's had no history of hypertension or renal disease. So I'm more concerned that this is an example of an acute hypertension. So someone who's had completely normal blood pressures in their life and all of a sudden has acute hypertension. So I think it's interesting to think about if hypertension is causing these symptoms and what the underlying cause could be. So I think that was a great point, but I'm excited to get more information.
Yeah, one last comment about the high blood pressure, the hypertension is I think I forgot to mention, hypertension itself can be an emergency. So what if we have a hypertensive crisis that could cause many different manifestations, namely congestive heart failure, especially if you have pre-existing diastolic heart failure. Renal disease could also manifest with hypertension, DIC. You could also get CNS issues, papilledema. So a number of different pathologies could we be dealing with malignant hypertension or hypertensive emergency as a cause of this. I'm not sure, but definitely, as Jack had mentioned here, Venn diagramming, shortness of breath with AKI and renal failure. The kidney could be the center or the what we should be focusing on here currently, but also paying respects to hypertension as a possible inciting effect, or the heart probably contributing to this as well. Back to you, Deborah.
Great discussion, everyone. So answering some questions, she just took the ibuprofen the day before that she was not feeling so good. She didn't travel recently, and she didn't have a history of high blood pressure. That was her first episode. And then in the emergency department, her blood pressure was 263 for 168. And her saturation was 99% on room air. All the other vitals, they were normal. And the exam, she had crackles at the lung in the bases. And she had hypertensive retinopathy grade 3 on the fundoscopy exam. And the rest, everything was normal. She was admitted in the ICU, and she had to start it on nicardipine drip, and the blood pressure was probably stabilized. And then I have some labs. I'm waiting for Leah. Okay, so white blood cells was 6.6. Hemoglobin was 10. Platelets 150. Sodium was 141. Potassium was 3.8. Chlorium was 105. CO2 was 22. Boom was 42. Creatinine 5.2. BNP was 18,000. I don't have her other creatinines values before, and I think I can stop here.
Wow, that really changes the dynamics of this case now. Madalena, should we split up? I'll take the exam. You want to take the labs?
Yeah, that sounds great.
You do that, yeah. So just what really jumps out at the vital signs is the blood pressure, as everybody correctly indicated in the chat, that there are a fair number of conditions that come to mind, but this is an astounding emergency, and it's imperative to get this patient to a setting to at least bring the blood pressure down into a goal range. What is the goal range at this moment? I'm not quite sure, but what we usually teach is blood pressure as high as 180 over 120 millimeters of mercury indicates a hypertensive emergency. And then you have to also wonder, I mean, this could be any blood pressure, high blood pressure, plus a end organ effects. And end organ effects could be neurological issues like intracranial hemorrhage, stroke, aortic dissection. You could also be dealing with certain obstetrical conditions, preeclampsia, eclampsia. You could be also dealing with endocrinopathies like pheochromocytoma. So a crisis with pheochromocytoma has a certain illness script, which we may have to consider here. So what is the goal? Initially, we need to bring down the blood pressure about less than 25% using various intravenous antihypertensives. So if you're dealing with, say, aortic dissection, I know labetalol we've used before. If the patient has gone into acute pulmonary edema, and it looks like there are some volume issues here, namely the orthopnea, and on the exam, basal crackles. I don't see a JVP, but with the orthopnea, basal crackles, this is quite powerful in indicating there could be congestive features with this patient. So what can you give? Nitroglycerins, very powerful. Nitroprusside. You got to be very careful you don't introduce beta blockers because we don't know what the patient's ejection fraction is, and you could actually induce cardiogenic shock. ACS, I'm very interested in getting a troponin as well in this patient. We see Madalena will comment about the labs. I'm not going to start talking about the labs at this moment, but she will at least support some of the things that we're discussing right now. So with ACS, again, nitroglycerin will be helpful. AKI, what I've learned is nicardipine can be very useful. And in the exams, we always know with the eclampsia, hydralazine can be very, very useful in that case. And I just read about scleroderma renal crisis. Recently, there was a tweet on Twitter. And in that case, ACE inhibitor is usually the agent of choice. What are we dealing with right now? I have no idea. I know the kidney's involved. And again, going back to if the blood pressure is causing the renal failure or if the renal failure is resulting in the hypertension and congestive picture. But I'll have Madalena comment on the lab to see if any of the labs support our current hypothesis.
Yeah, this is fascinating. So I think some of the things that I'm tracking, you also pointed out. So we have this really concerning hypertension, which was, brought down with medication. In terms of the labs, what's really jumping out to me is this creatinine, which we already knew was elevated. And, when we have that elevated creatinine, I really want to decipher, is this a pre-renal injury, intrarenal injury, or post-renal injury? And I think someone mentioned in the chat, I think a UA is something that will be really important here to see if there's protein in the urine, if there's glomerular damage, if there's some signature of an inflammatory process like red blood cells or red blood cell cast to see if there's a glomerulonephritis. And so I would definitely, get a UA. I think the other thing is that you pointed out, Ravi, is the BNP, which is elevated. So there are signs of heart strain clearly here. So I would want to get a troponin to evaluate that further. So another thing that if we kind of jump back to the CBC, what's standing out to me is that there is anemia and thrombocytopenia here. So, this could be a few things here, but and people also put this in the chat. Is there a hemolytic anemia occurring? So people mentioned a MAHA. So to evaluate that, you could get a peripheral smear. You could evaluate that further with a reticulocyte count. Get some liver studies to see if there's an elevated indirect bilirubin. So I think there's kind of a lot that is concerning that's standing out to me. I'm not exactly sure how to tie all of this together, but some things that I really want to get more clarity on are the kidney injury and whether we can localize it pre-renal, intrarenal, or post-renal, and then understand a little bit more of the anemia and thrombocytopenia with those additional tests. Ravi, anything else about kind of next steps you would do here or how you think you can tie some of these things together?
Wonderful analysis of the labs, Madalena. That was very, very, very good. I think I'm limited currently as to what's going on. I know this patient would need to go to the ICU, need to get that blood pressure under control. There's alarming features right now that we see. But once you get the blood pressure under control, then you start the diagnostic process like people are mentioning. I would start ordering labs. And now you mentioned something very interesting. MAHA could be part of the process. So I would order the whole lab panel for MAHA. I would, like you mentioned, troponin. We don't want to be sitting on top of a patient with ACS. Getting that EKG and definitely getting imaging. And we'll see what Deborah gives us in the next aliquot. Back to you, Deborah.
Okay, great discussion, everyone. So was done a chest X-ray that showed bilateral pleural effusion, an urinary analysis that showed moderate blood and large protein, but no cast, no white cells, no bacteria. And then some more labs was ordered C3, C4 that was negative. ANA, ANCA, all the rheumatologic workup. The thyroid studies, they were all normal. And the test for cortisol, renin, aldosterone are normal. And it was done in an ultrasound with Doppler that shows symmetric kidneys with no evidence of renal artery stenosis. And the next aliquot will reveal the diagnosis.
Wow, that's a lot of incredible information there. But Madalena, well, how does this help us?
Yeah, this is a tricky case. My gosh. Okay, so in terms of where I'm at, so we talked about with the kidney injury, wanting to characterize it as pre, intra, or post-renal. And a renal ultrasound helps to see if this is a post-renal. You can see evidence of hydronephrosis. And Deborah, do you mind just repeating, on the renal ultrasound, there's no evidence of, what did you say there?
It was no evidence, of renal artery stenosis.
Okay.
And was symmetric kidneys. Symmetric
kidneys, got it. So, so the fact that there's symmetric kidneys, I think that makes a post-renal kidney injury less likely. Then if we move on to, is this pre or intrarenal? From the UA, we see large protein, which is never normal because in a normal functioning kidney, the glomerulus should filter that out. So, and moderate blood. So it's, to me, what I'm taking away from that is there is some kind of intrarenal injury at the glomerulus because there is large protein. So you can kind of break that down. Is this a picture of nephritic syndrome, like an inflammatory process here, or nephrotic syndrome? They already did some of the workup that you would do for nephritic syndrome, like C3, C4, some of the ANCAs. But geez, what am I doing from here? I think what stood out to me is kind of the intrarenal injury from the UA. The fact that there's no evidence of renal artery stenosis is also very helpful, which could have also explained the hypertension we're seeing. I think in terms of next steps, I want to characterize a little bit more of the cardiac function because of the elevated BNP. So maybe getting, an echo of the heart to evaluate maybe the size of the chambers, its overall function would be a helpful next step. But yeah, Ravi, I would love to hear your thoughts. I'm a little bit stumped about how to be tying kind of the presentation of hypertension and shortness of breath into this additional data we have.
I think you pretty much have got it. I don't think we have an explanation. All I'm seeing is what you're seeing is ramifications of such a huge blood pressure. We see the dyspnea, we see the orthopnea, we see the creatinine elevation. We also see this hypertensive retinopathy grade 3. I'm not familiar with the grading though, but I assume it's pretty advanced. So we're seeing basically end organ damage, namely the kidneys and the eyes there. So with this case, again, I think it's imperative the concentration should be on getting the blood pressure down. As far as what is causing this, I have no idea. We were all stuck on or bent on trying to determine or pin the cause on the kidney, but we see large protein. But again, this could be due to the high blood pressure. But we're not seeing PAS. We're not seeing any signal for like a GN, all the C3, C4, ANA, ANCA, all of that's normal. Workup of secondary hypertension, the renal ultrasound, no evidence of renal artery stenosis. So a lot of it's been discounted. Now, aldosterone is normal. Does that rule that out? It can be episodic. So I wonder if a further workup or looking into this domain of hyperaldosteronism is worth pursuing. But at this point, I think just the ramifications of that blood pressure are pretty much front and center, and we need to at least bring the blood pressure under control. Now, what's causing this? I don't know. What was interesting earlier, we talked about scleroderma renal crisis, and there's other features. 37-year-old, we don't have any findings that parallel scleroderma as a diagnosis. Scleroderma renal crisis would have findings of scleroderma. You would have the kidney injury, you have high blood pressure, you have MAHA. So we're not seeing those features. We do see a lower hemoglobin. We're seeing lower platelets, but we weren't given labs for like the Billy and so on, haptoglobin. So the lab panel that would determine if there was a microangiopathic hemolytic anemia. But yeah, I'm sort of stuck right now as to what may be the central cause. But as all CPS VMRs, we do learn something every time we attend these cases. Madalena, did anything strike a chord with you there? The rambling I went through?
No, I'm definitely on the same page with you. I think Khalifa mentioned a really good point about sending metanephrines to just really fully evaluate the pheochromocytoma hypothesis that you mentioned. Deborah, I'm wondering on the vitals, you would expect to see some potentially palpitations that the patient would report or tachycardia. Did we have that information from the vitals, or was that not given?
I don't have the number, but everything was normal.
Everything was normal. Okay. So maybe that's a little bit less likely because you would expect some tachycardia, but probably still worth it to send metanephrines to rule that out.
I think that's a very good idea. Now, the latest encounter with a patient with pheochromocytoma I had was that it's intermittent. It just moment to moment, everything's fine. And then suddenly diaphoresis, blood pressure jumps, heart rate jumps. And you go from somebody being perfectly okay to suddenly being in a hyper anxious, sympathetic overdrive situation. So I'm sort of not getting that flavor here, but definitely, we've had so many atypical presentations of a disease. Not everybody reads the textbook or clinical vignettes that traditionally are taught to us, but I would still keep that in the running. But waiting to learn from Deborah, see what we have here.
So it was done a renal biopsy on this patient, and the findings was consisted with accelerated hypertension, and she was diagnosed with heart failure. And the the case resolution, like she had to take medication for oral hypertension, and she had like a malignancy hypertension that almost caused the ischemia of her kidney, and she had to continue taking the medication, and then she got better, she improved it. And yeah, so some teaching points from this case that I learned, it's like with malignant hypertension, it's the patients that can have more can be like Black patients, and it's show marked elevated hypertension and some chronic renal disease, particularly some diabetic neuropathy, and has to look for the laboratory, and the proteinuria normally is elevated, so that can explain. And the treatment in these patients normally has to reduce, like Ravi said, the blood pressure by 20 or 25%. And because if you decrease, may lead to a cerebral hypotension, cerebral hypoperfusion. So the goal, it's being like 125 and to 130 for 80. So yeah, that's the case, and great discussion, everyone. I tried to pick a cardiology case because Ravi likes a lot.
Oh yeah, Deborah knows. Give me cardiology, I could hopefully talk about it. But Madalena, this is an extremely important case because we do see it a lot. Blood pressure control is imperative amongst a lot of our patient population, and unfortunately, we have a lot of patients, or the patient population I serve has a lot of undiagnosed hypertension causing end organ damage. But what are your thoughts about this case?
Yeah, I think I definitely need to do some more reading, because I think I still have some questions. Like, I think Hans put this in the chat, what caused the malignant hypertension? Is that clear from the case, Deborah?
Good question. Let me check.
But we have one interesting, I guess, mechanism is like you have pre-existing high blood pressure. So what does the body do to compensate for the blood pressure? The vessels will harden, and you have different layers of the vessel, the media, intima, and so on will become very stiff. And what happens is hypertension begets hypertension, and then you develop this snowball ramp-up effect where the blood pressure will just increase, and suddenly spike beyond the means of the regulatory mechanisms of the body. So there's certain intrinsic mechanisms to prevent high blood pressure, namely the cardiac body receptors and so on. And when you get these receptors firing, you diurese. So ANP can be released. RAS system is turned off. But in some patients, there may be defects in this, and the blood pressure may surge extremely high, causing the retinopathy, causing CNS issues, causing aortic dissection, acute heart failure, AKI, and ACS. And there's also a mechanism where you can get shearing of the blood vessels and exposure of underlying tissue or collagen, causing DIC in patients. So it can be a very deadly process. Along the way, I would also check for cocaine. Cocaine could accelerate the blood pressure in some instances as well. So drug-induced hypertension, I would also worry about. But a large number of our community out there are not on blood pressure medications, and this could be avoided by having good primary care out there to at least help prevent these sort of issues. Madalena?
Yeah, I thank you for all that teaching. And I think what's, just going back to the beginning, it's so concerning. This was such a young woman, a 37-year-old woman who ended up developing heart failure and malignant hypertension. So I definitely going to do some more reading about kind of how this, kind of going back to like the underlying cause here, because she had no underlying history of hypertension or renal disease. So I think I'm really struck by how rapidly this progressed and how quickly she got these kind of end organ dysfunction, like the creatinine up to 5, the pleural effusions, the hypertensive retinopathy. So I think I definitely have some learning to do from this, but it was really a great case to kind of walk through how do you approach hypertension, if it's primary or secondary. So a lot of things I'm going to kind of go back and review, but learned a lot discussing it with you, Ravi.
Oh, same. Likewise. Thanks for discussing. Is much easier. Allowed me to think about the case as well, because going it solo can be a daunting task. But I really appreciate you stepping up to the plate. I just asked Madalena when she popped on, could you please discuss with me? And she graciously agreed to. So I really appreciate you helping out today, and Deborah for the fantastic case, and Leah for scribing duties as well. Deborah, any last words?
Yeah, I did some teaching point, but the most important pearls was about the malignant hypertension that I told. So it was a great discussion, everyone. Thank you for being here today with us.
Likewise, appreciate everybody for coming on today, and the fantastic team behind the scenes, Deborah, Leah, Madalena, for helping out today. I hope everybody has a wonderful rest of Tuesday afternoon. Bye.
All right. Thanks, everyone. See you later.